Hello class. I'm just going to kind of go over these case studies that represent the exemplar code status that we would have talked about in class today. Our concept obviously is legal, and I hope you've had time to go over your assigned reading and kind of reflect on some of the terms that I put on the board while you were taking your test on Monday or Tuesday. This first case study in Appendix 30 regards David Lewis. He's a 50-year-old African-American male who is recovering from a stroke at a rehabilitation facility. He's medically stable and able to participate fully in his therapies. However, he personally has requested a DNR, a Do Not Resuscitate status. And he reasons that if he has another stroke or a cardiac arrest, he could lose more cognitive and motor function. And then if he were resuscitated, he would worry that he would place too much heavy a burden of care on his family. So day after day, he and his family ask about the DNR order. The nurses working with Mr. Lewis repeatedly ask the attending physician for an order, and the physician continues to respond that Mr. Lewis does not need a DNR order because he's stable. Finally, the primary nurse goes to the facility's ethics committee to discuss the problem. So now the results are that because the nurse has taken it to the next level and has really represented a true advocacy for this patient, this will be reviewed by another physician, all the information in his chart. They'll probably do interviews with the patient and the family, and then eventually, I'm sure, concur that the patient will have his request of a DNR granted. Now, these are some of the dilemmas that we face where there is a disagreement about a DNR order between patient and healthcare provider. But remember, our focus is on a patient-centered care philosophy, and when our patients want this, and this patient is very, very mentally stable, very cognitively thinking, of sound mind, and he just feels that if this would happen again, it might be a more severe outcome, which would present him to be much more incapacitated, unable to care for himself, and he doesn't want to put that on his family. So looking at that first question, what ethical dilemma did the primary nurse working with Mr. Lewis face? And the nurse faced a conflict between the patient's rights and values and the physician's belief that a DNR was not appropriate. So there was really a conflict, and I have to really say that I admired this nurse a lot because today, with all the nursing responsibility, this nurse did not let this go. She pushed and pushed and pushed to try to get the patient's rights and the patient's request heard and hopefully initiated, and that DNR would be written. And you really have to admire a nurse who really sticks by her patient and really represents his feelings and his word to this ethics committee. So good for her. What principles did the primary nurse follow in going to the ethics council? The nurse identified the existence of an ethical dilemma and communicated with colleagues to seek a solution that addressed the needs of all involved. And she sure did. And that was the appropriate way to go because they gave this physician quite a chance to be able to recognize this patient's feelings about him wanting a DNR. But the physician repeatedly refused to write that DNR. So the only thing this nurse could do was to take it to the ethics committee. And I think sometimes the way we advocate for a patient really depends on what our feelings are, and that's why this next question, how do you feel about DNR orders and why? And I think if we look at why this patient wants a DNR, this is a way in which this order will allow an individual to make choices that are related to the quality of life and a dignified death. And they protect the right to self-determination in circumstances where the patients may no longer be able to advocate for themselves. So one potential problem may be that the patient may incorrectly conclude that quality of life would be impaired if they were resuscitated. So I think another responsibility that we have is to provide the correct information to our patients. That when they're stating that they want a DNR, do they know exactly what that means? And if they were resuscitated, what kind of life-saving measures would be initiated with him as a patient? So I think we need to make everything very clear and very transparent to this patient, so when they make the decision about the DNR, they're knowing exactly what's going to happen. And in what ways did the nurses working with Mr. Lewis advocate on his behalf, and how is the nurse's role as an advocate related to nursing ethics? And I think we have to look at our American Nurses Association Code of Ethics, and we need to know that nurses have an obligation to promote, advocate for, and strive to protect the health, safety, and rights of the patient. And although the patient wanted a DNR order, this request was ignored by the physician. So the nurse did advocate for the patient by initiating the process of an ethics review, and she absolutely did the right thing. So I think this is a real good example of some of the conflicts that we may encounter. And I think, too, we always have the support of our supervisors, and knowing that we're really representing our patients on a positive note and really advocating for that request to be granted, and that is, in this case, a DNR. The next case study, again, involves the exemplar code status, but it kind of has a different twist to it. In Appendix 31, Gary Casper has been in the hospital several times in the last year, and he has a deteriorating diagnosis. And after his nurse, who is Chandra Lewis, completes her assessment of Mr. Casper's current condition and his concerns, she contacts the case management department for assistance with his concerns regarding end-of-life care choices. But the nurse tells the case manager that the patient's wife will not allow him to prepare an advance directive, which Mr. Casper wants to do since he has decided to be DNR on this current admission. So the next day, the social worker meets with Mr. Casper separately from his wife to discuss his right for self-determination and how to prepare an advance directive form. So Mr. Casper now is relieved that he can complete the form in the hospital, but he's also concerned that his wife will still be able to prevent this, as he does not want her to have power of attorney for him. So plans are put into process for Mr. Casper to complete the advance directives with appropriate staff and another family member, while the medical provider speaks with Mrs. Casper in the conference room. So now we still have a ethical dilemma, but it's now between the patient and his wife. And I think you can see that this does represent support for the patient's right to self-determination. And self-determination is just a word that means the patient's right to make his own decisions and care for himself. So the staff did support Mr. Casper's right to self-determination by meeting with him individually and initiating the process of having Mr. Casper prepare an advance directive that is consistent with his own end-of-life concerns. And I think it's important that couples know that they can do this on their own, and they do not need the consent of their spouse. And in question 2, it says, did a medical provider violate the wife's rights to be with her spouse in this case? And the answer to that is no. Mr. Casper is a competent adult who has the right to make his own decisions regarding end-of-life care. So I think it's important that we let that spouse know that you do not need the permission from your spouse in order to complete this advance directive. And question 3 is, how can nursing staff further assist Mr. Casper in facing these end-of-life care decisions? And I guess there's other things that we can be doing that really are our responsibilities as nurses, and that's to assist patients to make end-of-life decisions, including providing emotional support, providing teaching about life-sustaining measures, and really trying to help correct some of the misconceptions and reassuring them that they always have the right to change their decisions when they are competent. So for instance, on Tuesday, if they really do not want any life saving measures, DNR, DNI, whatever they would like, if on Tuesday they feel one way, they can change it on Thursday of that same week or any other time. It isn't set in stone. And question 4, how can the staff support Mrs. Casper as she faces the end of her husband's life? And this is really hard for that spouse who's going to remain behind. Some of these people have been married for many, many years, and it's just very hard for that spouse to let go. But we as the staff and as a nurse can also help our families and provide non-judgmental support to Mrs. Casper by just listening to her concerns, acknowledging her feelings, and providing information that may help alleviate her fears. So I think she does want what's best for her husband, but I think sometimes she's afraid to let go, and that's why she's like, I want everything done for him, but unfortunately she doesn't see it through her husband's eyes. But I think if we can let her vent, let her express her feelings, and maybe offer a little bit of what may happen, she may feel a little bit better about the situation. So those are the 2 case studies I wanted to talk to you about in regards to code status. So now I'm just going to go over the PowerPoint for scope of practice. Here's this PowerPoint, and our exemplars are scope of practice and accountability. And I've talked a little bit about this the other day after the test, where each state has a Nurse Practice Act, which defines the scope of practice, standards for education programs, licensure requirements, and grounds for disciplinary actions. And this Nurse Practice Act is enforced by the State Board of Nursing, and I talked about that, that happens to be in Columbus, Ohio. With our licensure as registered nurses, it allows us as nurses to have that legal privilege to practice nursing as defined by each state's Nurse Practice Act, and then each Board of Nursing oversees the administration of a licensure examination, and that's the one you guys will be taking after you finish this program successfully. And the associate degree program, the diploma school degree program, and the baccalaureate degree program all take the same NCLEX. The LPNs take a different NCLEX exam. And as nursing students, yes, I know you're all in a learning mode and obviously do not have the knowledge and experience, and that's why we provide clinicals and labs to help give you that experience in taking care of patients and know what to do as far as skills. But you do have a responsibility as a nursing student. There are guidelines for clinical performances. Each time you go to a clinical experiences, your instructor is overseeing whether or not you're making your clinical, you're achieving your clinical objectives for that week. You need to make sure that you're ensuring patient safety, that you know the facility's policies, procedures before undertaking any clinical assignment, kind of what their routine is there. And that is all learned through the guidance of your clinical instructor. And to ensure knowledge about your patient's condition, interventions, medications, and treatments, that the more you know about your patients, the better nurse, and the better you can provide very, very safe care to that patient. Never perform care if unprepared, and always seek help before beginning procedures, even if unsure. Even if you've been checked off, say for instance now you guys have been checked off in Foley insertion, you probably aren't going to be doing that for the first time by yourself. So you will have your clinical instructors there to kind of support you and guide you along. And just probably give you that confidence to know that you can do it correctly, and also to have confidence in front of your patients to look like you know what you're doing. So that's your responsibility as a nurse. Remember, you do not practice under your instructor's license. That's her license. She practices under her own license. You do not practice under the instructor's license. And we have these 2 words, accountability and responsibility. And accountability is answerable for the outcomes of a task or assignment. Nurses are accountable for their own actions, as well as accountable for the actions of their subordinates and their trainees. And it is a responsibility for many out there to perform a specific task or a specific accountability or liability. and it's associated with the performance of duties of a particular role. PCNAs may have the responsibility to do all the AccuChecks on the floor, but you're accountable to know that those all have been assessed and that all the patients have received the proper insulin coverage if they needed it. So you can kind of see the difference between responsibility versus accountability. Within our standards of practice, it's a description of responsibilities, a minimal level to ensure safe, effective care, acknowledging accountability for both successes and errors, help professional culture remain positive. And remember now, we have people out there that are much more educated than they were years ago, and I'm sure that's attributed to the fact you can get on the internet and look up diseases and, how they manifest, and, there's WebMD. So, we as nurses also are more educated, so we can provide that knowledge to our patients. So we are working with a patient or a consumer who is better educated. They're more knowledgeable about health and illness. The TVs now provide, commercials about certain medications. So it gives those individuals who might have a disease or illness that would benefit by that medication, they might bring that to the attention of their physician and say, hey, I saw this new med on television. Do you think that would benefit me to help better control, say, for instance, my diabetes? So aware of others' needs for care, public's concept of health and nursing. Remember, health is a right. Individuals must assume responsibility for their health, and that's what we're trying to, promote, especially with what we call patient-centered care. And we want our consumer, our patient, to be an active participant in their care and to make their own decisions about their care. Again, science and technology have really helped affect our nursing practice, competence, and even to be more accountable. Look at AccuCheck machines. We didn't have that back in my days when I graduated. So it provides more of an accurate blood sugar that we can know right away if a patient is hypo or hypoglycemic, and it helps to make our jobs somewhat easier, so we know right away if our patients are in trouble with their blood sugars or their blood pressure or an EKG monitor or whatever all the new technology gives us to better care for our patients and maybe to detect a problem early before it really gets to be much more serious. Innovations have changed nursing education. Look at you guys bring your computers to class. We provide you My Nursing Lab, which is provided through the internet. You guys have been given your ATI books along with the ATI website where you can get in there and practice test questions, and you can do these pre-tests before you take your ATI fundamentals test after your final. Look what we've done for you in the lab. We've provided a lot of real-life situations with simulation and all the different high-fidelity mannequins that are out there. We offer our students various clinical agencies that help provide you the experience you need in that particular nursing course. We're so fortunate to live in Northeast Ohio, where we have all these various hospitals that we can send our students to get that all-important clinical experience to make them better nurses after they graduate. And again, within our nursing practice, accountability is influenced by individual values, beliefs, and values that are ethics inherent to the profession as a whole. Social factors are supported or undermined by individual RNs and development of the nursing profession itself. So just a little recap of some of your reading, and again to kind of concentrate and reflect on what our scope of practice really is. I wanted to go over Appendix 32 and 33. Here is that Appendix 32 that kind of answers the question, is it in your scope of practice? Hopefully you have this in front of you. I think it's in your packet of forms. You might see this article outside this square. I'm trying to get it centered as best as possible. This is a great article written by this Jennifer Nolan, who has her BSN. I'm not going to read the whole article, but I think it really talks about, as a nurse for a number of years, I think I know my own scope of practice. And as a nursing student, I heard the phrase a lot, read definitions, but they didn't mean much since I didn't really have any practices to fit into a scope yet. And that makes sense because she was just a student at that time. So let's take a look at what that nursing scope of practice is and how it is determined. To understand your nursing scope of practice, you must first know what defines nursing. And so the ANA provides this contemporary definition. Okay, I'm not going to read it to you. It's the one in bold print. Okay, that sounds like a fancy variation as I want to help people. Okay, and that's what we want to do as nurses. That's the bottom line. And as nurses, we commit to protecting the health of ourselves and others through education, hands-on care, collaboration with other healthcare professionals, and those others we talk about can be found in hospitals, schools, neighborhoods, free clinics, doctor's office, and next door. So again, what determines that we are within our scope of practice to work with these other people? So again, we can go back to that ANA and nursing scope and standards of practice that describe the who, what, where, when, why, and how of nursing practice. And each of these questions must be answered to provide a complete picture of the dynamic and complex practice of nursing and its evolving boundaries and membership. The profession of nursing has one scope of practice that encompasses the full range of nursing practice pertinent to general and specialty care. And the depth and breadth in which individual registered nurses engage in the total scope of nursing practice are dependent on their education, on their experience, role, and the population that they serve. So I think this is good what she starts talking about. She says, now we have this textbook definition. It tells us we must answer certain questions to know something falls into our scope, and it tells us there are lots of variables. So let's break it down, because even though we all went or are going to nursing school, because we all have or will pass our licensing exam, doesn't mean we belong everywhere. For example, I'm an OR nurse. I know a lot about anatomy, technology, machinery and instruments, positioning, pressure points, and personality quirks of my surgeons. I am not an ICU nurse. I know how to take a blood pressure, use my stethoscope, and I actually still remember the differences between wheezing and rales. I no longer know how to set up a pump. I'm unfamiliar with the many kinds of cardiac drugs used today, and I haven't managed a ventilator since nursing school clinicals. Those skills are not in my scope of practice. But here are some guidelines to determine your own scope of practice. Every nurse, everywhere, should know how to take a manual blood pressure. It's a basic skill taught in nursing school. So if you determine that that activity was not part of your basic nursing program, then try these questions. Did I learn this skill task as part of a comprehensive training program which included clinical experience? And many of you will do that after you get out of nursing school. You may go into a specialty area like OB or critical care or whatever the case may be, or work in a pediatric burn unit. And so you will be an expert in that type of nursing practice. And the next question is, has this task become so commonplace in nursing literature and in nursing practice? Wound debridement and dressing, for example, that it can reasonably and prudently be assumed within scope. At one time, only doctors attended to patients' wounds, but wounds of all kinds, burns, diabetic, surgical, are so commonplace today that pretty much all nurses know or have been shown how to do it. So I think you have to look too, is the skill task in your hospital's and clinics agency's policy and procedure manual? If it is in the book, your employer believes it is a skill task as part of your job that you were hired to do or your scope of practice, okay? So if you can answer yes to all these questions, then that skill or task is probably in your scope of practice. Scopes of practice are the same for every nurse at a basic level and very different by specialty, and those are all the many specialties that she talks about. So I think it's just kind of good to reflect on. It is always better to hesitate, ask yourself these questions, and check with someone else before you commit your patient or yourself to a course of action you shouldn't be on. Stepping out of your scope of practice can be a legal issue and endanger that license that you work so hard to do. And when I worked in critical care, I was an ICU nurse or a CCU nurse. So if I got floated to peds, I didn't do anything that I was not comfortable with. I didn't give even pediatric medications. I could take a blood pressure. I could assess a baby to see if they were in respiratory distress, but I did not do anything that was very pertinent and special to what you would do for a pediatric patient. So I thought that was a really good article to kind of look at what your scope of practice is. And then we have this next case study, again, representing our exemplar scope of practice, recognizing signs and symptoms. At first glance, Nurse Rhea can tell Mr. Paul's condition has changed. As she asks him how he feels, Rhea notes he is short of breath. She can hear the anxiety in his voice as Mr. Paul replies that it's hard to catch my breath and his chest feels tight. So she knows Mr. Paul was admitted overnight with general weakness and anemia after a fall at home, and there was no record of any shortness of breath or pulmonary disease in his admission history. This following paragraph is an assessment that Rhea made about this patient. She does realize that he's feeling dyspneic, short of breath, so she elevates the head of his bed so he can sit upright, and she begins her assessment. She notices his respiratory rate is 32. She notices that he's using his accessory muscles, and she notes that his skin is a little clammy and cool, and his lips and fingernails are slightly cyanotic, and she hears crackles throughout his chest, and she does not hear any good breath sounds on that left lower lobe, and his pulse is going up to 110 beats per minute. It's regular, and blood pressure is 108/60, and his O2 sats are 86% on room air. So any nurse should be able to detect by assessing a patient in this situation and coming up with this data that the patient is definitely hypoxic. So she diagnoses hypoxic related to that decreased air entry to his left lower lobe as the likely causes of the symptoms, and she knows how to improve his condition temporarily by applying oxygen and stabilizing him until a physician or nurse practitioner can diagnose the underlying medical problem. She knows he's hypoxic. She may not know what the problem is, but at least she's determined that there is a serious issue going on. So in deciding to treat, Rhea considers the risk, benefits, and possible outcomes. In her judgment, the outcome is reasonably predictable and the benefits outweigh risk. She has the knowledge, she has the skills and the judgment to follow her agency protocol for treating hypoxia, including managing any intended and unintended outcomes. So she gives him a mask at 6 liters per minute, and she just watches how he responds to that oxygen. And so within a few minutes, he's somewhat improved, and his respiratory rate slows down, and his O2 sats increase to 90%. So wanting to contact Mr. Paul's physician, she uses the call bell to alert a colleague to come. And I thought that was great that she used that judgment to make sure that the patient wasn't left alone, because remember, she just implemented this oxygen. She saw that he was improving, but you know what? If she left the room, he could very easily go the other way and start spiraling downward. So she wanted somebody to stay with him while she went out to the desk to call the doctor and receive additional orders. So she updates the care team, and she documents her ongoing assessment, diagnosis, treatment, and communication with the physician. And so it's important to kind of ask, what conditions might you diagnose and treat in your practice? Many times you might note if a patient's having hypoglycemia. Maybe they might get very tachycardia. Maybe they might start getting shaky. They might start getting cold and clammy. You might also, assess chest pain. You may not know what the chest pain is from, but you may be able to treat that. So do you see your process reflected in the steps Rhea takes in diagnosis and treating Mr. Paul's condition? And what else could this nurse have done for the patient that is within this nursing scope of practice? She couldn't give any medication, but she positioned him so that he could breathe better. She gave him that oxygen. She stayed with him and provided some physical support to him. And, and just kind of continued to assess him in all the ways that she did initially. So I thought that was a really good way to kind of say, what can you do for these patients that are still within your scope of practice? Class, I'd like to now show you just a short video, just to kind of hopefully help you understand the difference between responsibility versus accountability. I found this very short video and I think it's very helpful. So hopefully it plays good for you, okay? And that you're able to hear it. So it's just a very short video. So I'll let you view this.
Welcome to another brief session with Ruth Sanderson from Blue Pea Pod. And the question I've got for Ruth today is, I'd like, as a leader in my organisation, Ruth, to be giving people more responsibility. And I know there's lots of talk about delegation and empowerment and stuff, in many organisations, not just ours. Can you maybe share a few tips for us on how we can effectively, give people more responsibility?
Okay, so there's one thing really around you give responsibility, and I think as a leader the first thing you need to get clear on is responsibility and accountability. So before you do any delegation, before you do any empowerment, you get clear on responsibility and accountability, because they're a bit different.
Well, could you expand a little bit on those differences then? Because I know we probably interchange those words.
Yes, it's very, very common. So responsibility is when somebody turns around and says, I have given you this particular task and you are responsible for delivering the task in a way.
Yeah.
So we either tend to go, I've done the task or I haven't done the task. That's it. But accountability is this sense of ownership for an outcome. That's beyond the task.
Right.
So it's almost like the bigger picture. So I'll do whatever it takes to get the outcome. Starting here, I can think it can involve A, B and C.
Yeah.
But as I'm doing it, I may then also see that it involves this and this. But because I'm accountable for the outcome, the result, and I have that sense of ownership, I will do whatever it takes. Now, when I say do whatever it takes, I don't mean that I have to be the one that does it. Sometimes I'm the one that says, right, okay, I need to have a conversation with that person. So I do whatever it takes to make sure it happens,
Yeah.
but all the time I have kept ownership of the outcome. And when people are just doing responsibility, and as you delegate down, you want them to have that sense of responsibility.
Yeah.
But things can fall through the cracks. Because it's like, well, I'm just doing A, B and C.
So it's almost like the responsibility part is very sort of task focused is what I'm picking up, whereas the accountability is, accountable for something much bigger, put it to fruition.
Yes, the outcome.
Yeah.
Yes. So I feel a sense of ownership.
Right.
So I can feel a sense of ownership for a brand. I can feel a sense of ownership for my business.
Yeah.
I can feel a sense of ownership for a project. I can feel a sense of ownership for me. So I am accountable for all my actions.
Right.
Yeah? And it moves it on a level from responsibility.
Right.
And when you're working in a team and you've got several people doing things,
Yeah.
one person always has to be accountable.
Yeah.
Everybody else can be responsible for things, but one person always has to be accountable. Because then they won't let things fall through the cracks. But if nobody feels accountable,
Yeah.
everybody's doing responsible, you see that fabulously in silo management. Because that's when things, it's like, well, that's the job of that department, that's the job of that department.
That's not my job, it's the language that's often heard, isn't it?
Yes.
That's great. Well, that's lovely. That's probably the most I've understood about the difference between those two things. So thank you. That's great.
Class, I hope you found that video helpful in understanding those two terms. I just want to kind of go over a couple questions on accountability. This first one is in your Appendix 34, linking the concept of accountability with the concept of legal issues. I think it's good to think about what is the nurse's legal obligation to the patient related to accountability and how is it regulated. And my answers are here in red, where nurses are accountable for providing quality care to our patients, and care is to be given according to recognized and approved standards of care, which are used to legally define care. The second question I think is quite appropriate because we do see so many med errors being made. A nurse makes a medication error that results in harm to the patient. The nurse demonstrates accountability by immediately informing the physician and nursing supervisor when the error is recognized. And how does the nurse's proper demonstration of accountability affect the nurse's legal responsibility? And the demonstration of accountability does not affect long-term legal responsibility for the error, but the nurse is to provide care according to standards of practice. If these standards are violated and result in an error, the nurse is legally responsible for the outcome. And hopefully she adheres to the policies of the hospital or the facility in regards to a med error. Usually incidents reports are made out. The physician is notified. Usually if it's a serious error, the patient will be assessed and checked out by a physician or a hospitalist or whatever, just to be sure that the patient is not suffering from some serious outcome or side effect from the med error that was made. Question 3, what is the nurse's role in assessment and appropriate interventions to ensure comfort for your patient? The nurse is responsible for assessing the patient's level of comfort and providing effective interventions. And that's kind of that additional question we ask our patients at the time when we do vital signs. Are you having any pain? And then we go into details about the kind of pain the patient's having. So that is very important because we don't want our patients to have pain, and we want to find out what's the origin of that pain. The frequency of assessing the patient for comfort depends on the patient's health condition, and the findings of this assessment are to be documented. And sometimes it's not only physical discomfort. We've talked a lot about this. It could be the mental discomfort. If your patient's in extreme anxiety or stressing about something, they just heard that they're in the hospital and one of their kids has a problem and she can't be there to help her children or her husband or whatever the case may be. Question 4, how does lack of patient comfort impede the patient's taking part in care plans and activities? And that's a great question, because when our patients are uncomfortable in both body and mind, comfort is needed to be present in order for those teaching moments to be absorbed and learned and understood as to why they're being done. It also brings your patient involved in the situation. And if our patients are uncomfortable, learning will be impeded. And if the patient is uncomfortable, the patient won't want to participate. You're not going to have somebody who's cooperative and interested and excited. And that's sometimes how you as students feel. You come into class, and if something's going on personally, it's very hard for you to engage in the activities or the learning that we're talking about in class that day. We can now look at linking the concepts of accountability with the concepts of ethics. How does the nurse's code of ethics reflect the expectation that the nurse is accountable when providing patient care? A code of ethics is one criterion of a profession. In nursing, the code of ethics guides behavior when providing client care, and by following the code of ethics, the nurse demonstrates accountability with client care. It's more than just a task. She's hopefully producing certain patient outcomes. A nurse believes that the physician has written orders that may endanger the patient. The nurse consults the physician who refused to alter the orders. What is the nurse's ethical obligation to the patient in order to demonstrate accountability? She is responsible to that patient and therefore must take action to prevent the client from harm. This action might be in the form of contacting the nursing supervisor, medical director, or other organizational administrator who can intervene to support the nurse's action to protect the patient. The nurse is responsible for providing quality care, which includes questioning orders that may be harmful. Because of the incredible amount of knowledge that we have as nurses, we should know when something is going to provide harm to our patients. Maybe a medication error, maybe some kind of treatment. because, you know, if you provide that medication as the doctor orders it and harm does come to the patient, you will be accountable for that action. And you can't say in a court of law that I did it because the physician ordered it. You knew better, you knew that it wasn't safe, but you went ahead and did it anyways, and now harm has come to your patient. So I wanted to go over those questions on Appendix 34. And then just to go over Appendix 35, again, representing our exemplar accountability. Here we have a situation where we have Jen Sturgis, who's a fairly new RN, and she's on a medical unit in a fairly good-sized hospital, 245 beds. And she has 5 patients she's assigned to. And one of them is a 45-year-old named Catherine Miller. Came in with a diagnosis of a GI problem and also had a history of back pain. And during Jen's assessment of her pain level, the patient said she was doing just fine, but she seemed very anxious. And the more she assessed this patient, she noticed that her blood pressure was higher. And Jen even said that to the patient. And the patient described trying to overrule her body by ignoring its signals and having a dialogue between the body me and the real me. And the patient said, if I refuse to pay attention to my body, my pain will go away. And then Jen realized that Miss Miller, although actually in pain, might not be allowing herself to pay attention. And Jen asked the patient if she had discussed her pain management with her primary health care provider. And she laughed and she said, oh, my doctor tries to have me take narcotics, but I worry about those types of meds. And as she spoke, her hands were gripping the bed sheets and she was shaking. She said, the pain is my enemy and I don't talk to my enemies. And the nurse right there, even being a new nurse, knew that ignoring those body signals of pain can cause some very serious consequences. The pain could intensify and the patient's blood pressure could rise very significantly. And she realized that she needed to get appropriate treatments for her pain. And after she did her assessment, Jen, the nurse, discussed with her unit charge nurse the concern she had about this patient's pain and her need to try to find some type of pain management as well as hoping to provide some comfort for this patient. So these are some of the questions after reading this little case scenario. Why was it important for Jen to complete her patient's assessment before leaving the room? She needed to complete her assessment before leaving the room to have a thorough assessment done, and all data needed to review prior to speaking with the charge nurse or possibly the patient's doctor. So she really needed to get all the facts in play. And what further symptoms did Jen observe while she spoke with the patient? She really did observe her anxiety level. The patient did report a pain level, and she noticed that the patient really had an elevated blood pressure. So what information should Jen share with the charge nurse to assist in meeting her patient's needs? She pretty much talked about all the objective data that she definitely concurred with the patient. But she also talked to her about the patient's beliefs of pain management, along with how much anxiety that she saw with this patient. And these are some other people that they could collaborate with to help find a way to come up with a plan of care with the pain pharmacist, the physician, or the social worker to help alleviate her pain. And we really want to try to provide a plan of care that is very individualized with this patient, along with having it meet the patient's approval as well. So in this Part B of the case study, she clearly discussed with the charge nurse her concerns about Miss Miller's pain management and the objective symptoms she noticed during her shift. And I think what worried this nurse was that if she was concerned about the patient, she would not be able to participate in her care because of course, the high intensity of pain that she was experiencing. And it seemed that the patient was very worried about pain and narcotic abuse, and The nurse also felt that it was very worrisome about the way that this patient reacted to pain. And I thought she was very kind, because as she listened to her patient's fears and concern, she held Miss Miller's hand and told her how important it was for her to take part in her care and to allow staff to help her manage the pain and to try to keep her as comfortable as possible. And to help with this care, she said, I would like you to see our social worker and clinical pharmacist to see you about your pain and needs while you're here. So she agreed with this plan. And so, as the charge nurse, she did take an Miss Menendez took an active role in further assessment of the patient's needs and communicated with Miss Miller in a truthful and calm manner. And of what aspect of ethical principles listed in the Code for Nursing Students is this an example? It is an example of communicate patient-client care in a truthful, timely, and accurate manner, and it's also an example of advocates for the rights of all patients. And if Jen had waited to collaborate with the charge nurse, would this have prevented further care and appropriate client outcomes? And of course, the answer to that is yes. The patient needed clarifications of her concerns and support of her care plans and needs. So I think those are two great examples of accountability, because this nurse was accountable and hoping to reach positive outcomes to make sure that this patient could have or set up a care plan or develop a care plan to help alleviate some of the pain that this patient was experiencing. So this concludes just this short discussion about the legalities in nursing with the exemplars of scope of practice, code status, and accountability. Thank you for your attention.